Well, good evening, everyone. Welcome to the Brian Crombie Radio Hour on Saga 960. It was almost a year. It was actually a week longer than a year ago that I first had Alex Vezina, CEO of Prepared Canada, on my show to talk about COVID-19, because we were just at that point in time talking about what to do and how to prepare. And Alex, who is an emergency preparedness expert, and he's got a master's in emergency preparedness, runs a company that advises organizations and companies on emergency preparedness, was telling us about some of the things that we needed to think about. Hard to believe that it's been a year and we're now into what, Alex, the third wave?
Depending on where you are in Canada, yeah.
And I just saw a front page of the New York Times, Sunday New York Times, that showed that this is the worst peak so far internationally in COVID-19, primarily because of adding up what's happening in India and South America to the numbers that we are so familiar with in Canada, the United States, Europe, etc. And it appears that India is just a unbelievable catastrophe. Tell us sort of where you think we are and where we're headed.
Where we are within the pandemic, specifically, like right now today?
Yeah.
Depending on where, when you say we, do you mean Canada or you mean the globe?
Both.
Okay. Globally, we're farther along in a positive way than we thought we were going to be, because the reality is that the vaccines are very early. We're well ahead of schedule of where we thought we would be at this time in 2020. So we're actually in a good place, scientifically speaking and epidemiologically speaking, in the pandemic. We expected the pandemic would go for longer, and we expected the deaths would be higher. So globally, we're actually in a very good place. Similarly for Canada, actually, Canada is about 6 months to a year ahead of schedule on vaccine as far as the rollout is concerned, or as far as what we thought was going to happen. So we're actually in a relatively good place, even though the numbers are so high. Let
me ask you about that for a second, Alex. You know, the federal government in Canada has been getting a huge amount of negative press and challenges from the other parties that we're behind on the vaccine rollout. Why do you say we're ahead?
Well, I penned a piece on this for Post Media about 2 months ago, saying that people are focusing on the wrong thing entirely, which is something that I've said to multiple people, which is irritating me to no end. The reality is it was supposed to take us over a year to develop the vaccines, let alone produce and distribute them. Canada isn't a production center, and the only places that are remotely getting vaccinated are the places where they're producing them en masse and large scale. And even some of those places are having a really tough time. Canada isn't a production center, and it's still very high up on the list for how quickly people are being vaccinated, frankly. Further, the expected timeline for when this was supposed to be done, when we were supposed to look at getting our immunizations done, was supposed to be summer 2022. That's what we thought the target goal was. We're way ahead of schedule.
Thought when? A year ago?
Yeah, like when Canada made the decision that we were going to be in this for more than a year, and that we were going to have to adopt the wait and pray for vaccine strategy. When that was adopted, it was assumed the target date, best case, was going to be basically summer 2022. We're way ahead of schedule, strategically speaking.
And
now,
so
one thing. When you adopt that strategy, you assume you're going to have to hold on until 2022. This means that the government assumed that we're going to have to hold on to 2022, and then did not put in the stuff necessary so that we could hold on until 2022, because all of the hold on measures are failing. That's my issue. I don't have an issue with the vaccine. I have an issue with we're supposed to be putting stuff in place to be able to hold on until 2022. We're halfway to that point, and our measures are already failing.
And what are those hold on measures that are failing?
Business survival, CERB, the long-term care homes, version 1 and version 2, everything that's not the vaccine, the stuff that we were supposed to have to do to hold on for 2 years so that the vaccine could save us. That's the strategy idea. Those measures failed in half the time. That's ludicrous.
So our survival measures failed in half the time, but thank God the vaccines got developed in half the time.
Yeah, but we had no control over the vaccines. And when you set a target, of we think we're going to be saved by this date, best case scenario, and you plan to live until that date. It's like rationing food. When you buy a bunch of food and then ration it because you expect, the nuclear winter is going to be over in your fallout bunker in 10 years, you don't eat all of your food in 5 years and hope that it's over. Like, that's crazy. And I'm sorry for the inappropriate use of the word crazy, but it's just, from a disaster management or emergency management point of view, this makes no sense to me. Why people are not furious about the fact that these measures that should have lasted for longer are failing already. And we're all mad about the vaccine. Like, the miracle isn't here fast enough. So let's let all of the obvious stuff they should have done better go. Like, it just doesn't make sense to me. That's my pet peeve thing. So I have no issue with the vaccine rollout whatsoever. We don't have enough supply. We weren't supposed to even have supply right now. That's fine. I have serious issue with all of the other stuff that we're just failing on categorically, which we can go through a list on. And there is quite a list.
We're chatting tonight with Alex Vezina, CEO of Prepared Canada, an emergency preparedness expert on COVID-19. And he says that the vaccine, the miracle is here in half the time, but where we failed is all of the measures that were supposed to help us get to that vaccine that were supposed to last until 2022. We've given up on them in 2021. Stay with us. We're going to take a break for some messages and come back more with Alex in just a minute. Welcome back to the Brian Crombie Radio Hour on Saga 960. We're chatting tonight with Alex Vezina. He is an emergency preparedness expert. He has a master's in emergency preparedness, and he's been someone that I've been, looking to over the course of the last year for some advice on how we've been doing with COVID-19. Alex, your hair's getting pretty long.
It is getting long.
What's going on, buddy?
That is actually a long explanation, and I think it will detract from the value of the conversation. I will try to make it simple. I have a barber / stylist that I've had for many, many years. The pandemic is hitting him really, really hard, and it is good for his mental health if he and I can play the game of, hey, let's see how bad the hair is getting, and he can laugh at it over the pandemic. And I periodically send him money for the haircuts that I'm not having because it means that he can financially survive, and we get to laugh at my hair, and it keeps him sane. So, you know what? If my hair needs to be a bit out of control to make one person's day a bit better, then have fun laughing at me. It's all good. That's the short version.
That's actually a good story. I appreciate that you're sending money to your barber stylist.
He's been good to me since I was a teenager, so I'm good to him.
Alex, you say that the measures that were going to get us to the vaccine have failed. Why have they failed? Is it lack of leadership from politicians? Is it lack of confidence that the public has in them? Or is it that we've all just got tired so much more quickly and we're not resilient enough?
Okay, so a few different things. First, when I say failed is subjective, and what failure means can mean a whole bunch of different things. So just being careful what I'm saying here. Failure in this context would mean not producing the result that we want by a significant degree. So we expected a certain level of protection. We've gotten significantly less. So the strategy has failed because it hasn't achieved the intended result.
And this was masks, physical distancing.
Well, no, I'll go into the specifics, but just so you know, I just want to contextualize that.
Understood.
And the way that they fail is specific. So, for example, when you look at the long-term care homes, failure, which I'm assuming most people are familiar with by this point. The long-term care home failure, there's a few different parts of it. The first is lessons learned from SARS. SARS was largely spread in Ontario through the healthcare system. So the healthcare system itself is what spread SARS, people in emergency rooms not being separated and nurses going from hospital to hospital. Essential staff with a medical background spreaded a virus, and that was supposed to be our lesson learned. In the long-term care homes, people coming into and leaving long-term care homes and going from care home to care home is what largely created such rapid spread with a less transmissive version of COVID at the time, by the way. It's the same type of spread that we had in SARS. This is a lesson we should have already learned. That type of failure where you don't learn your lesson from a previous pandemic, there's multiple failures there. There's a failure of teaching the public and teaching staff, which is part the fault of the long-term care homes, part of the fault of the government, part the fault of sectors, that part the fault of frankly the people for not caring. And when I say that, I know that's a pretty harsh term, but the reality is when you look at the amount of political will that's been put towards long-term care homes in the last 30 years, for all intents and purposes, the Canadian public just doesn't really care. They don't vote with their wallet. They don't vote for it. They don't pressure their politicians to fix them, so they don't get fixed. There's a limited number of issues that we can care about, and we don't care about it enough for it to get fixed. So there's a whole bunch of reasons why that one failed. That's one thing. When you
hold it.
Yeah.
Let's stay with that for a second. So there was a judicial review after SARS, and it came forward with a bunch of recommendations. Some of them that you've just mentioned. One was, the people that were going from long-term care to long-term care, and said that we need to have full-time employees, not part-time contract employees that get dedicated to serving only one long-term care facility and don't take them from one to the other. And according to numerous different people, we've got worse, that there's more part-time contract people and to make their living at terrible wages and to make ends meet, they're going to 3 and 4 different long-term care facilities a day. In addition, there were recommendations to keep PPE, personal protective equipment, supplies, both at the long-term care facilities as well as the provincial reserve, and ventilators, respirators. And from what I understand, we stopped doing that a couple of years after SARS. And the ventilators and respirators that we had, we allowed to not be maintained and became useless.
Yeah, well, there's that part. There's also a few others. It's been an open secret in certain government ministries that the risk of long-term care homes is a joke. Like it's been an open secret that you and this is pre-COVID that if you heard the way that people talk at their jobs sometimes, but if it's been an open secret that we have this risk, and then there's those people. It's like, yeah, okay, it's long-term care homes, whatever. Like, and that's the type of way that they're talked about, and that's been happening for a very long time. There's a mentality problem around respecting the issue. That's one thing. The second thing, not appreciating that people are the vector, and moving people from location to location goes beyond just full-time, part-time staff. The biggest risk for spread that I told most of the GTA school boards in July of last year, the biggest risk that they had was the French and the music teachers going from school to school because they don't have enough of them. When you have one person going to multiple schools and multiple classrooms, they are the common denominator. And if you don't control that, you're not going to control COVID, especially when it can spread up to 2 weeks pre-symptomatic. Same problem with people moving from place to place in long-term care homes. If it wasn't going to be the underpaid part-time workers, it was going to be the inspectors. The inspectors may have been the ones who ended up spreading COVID because you still have someone going to multiple buildings. Doesn't matter. So you need to eliminate people going from multiple buildings. And we don't think like that. There's a few people in public health who think like that, but Canada just doesn't have this learned yet. We haven't learned that. So that's a fundamental problem that you see all over the place in multiple organizations. And there's a whole bunch of different ways to fix it, but just because you fix one problem doesn't mean you fixed the problem. You need one person to get into that long-term care home with COVID, and then it's over. One doesn't have to be the medical staff or the service staff. It can be the inspector. It can be anybody.
And a visitor. Okay, so failure number 1 is long-term care. What's failure number 2?
Okay, so general public health messaging, and you can see this across multiple countries. And this isn't directly at public health. This is because the government, public health, and all of the response together kind of have to have a unified message. So the crisis, really the communications on this have been abysmal. The public has a limited attention span. This is something that we know and we understand. We design political campaigns, we being, North America, Canadian culture, designs political campaigns based around people's limited attention span. So we already know how people work and how they listen. We took a very, very complex message, we made it more complex, and then we gave people all the information and then showed them us arguing with each other. You showed the professionals arguing with each other. It's like not having your attack ad on your political campaign, but instead advertising everything that happened in the war room. Are you insane?
So you're effectively saying Roman Baber, when he disagreed with Doug Ford and Doug Ford fired him from caucus, that was the right move, that you needed to have solidarity in the message.
Yes, but that's not the point that I was really getting to. That is true because of a variety of different things, especially with how you have to run a crisis. But this is more about the, mask on, mask off, max on thing, right? Like that was made way too complicated. You can do the flip-flop message and explain it, but it was made way too complicated. There was so much lost.
Okay, so let's talk about that mask on, mask
no,
off. What was the flip-flop? Why was the flip-flop?
Okay, one more thing before I get to that, because there's an underlying point here that I want to make sure that I get across. Other countries focused on showing people how to wash their hands, explaining how distancing works, and putting up easy signage that showed you the distance. We have 6 feet or 2 meters signs that are on an 8.5 by 11 piece of paper. And people don't get spatial representation unless you show them the space. We didn't train the public on the measures. We basically told them, you are the enemy, everyone's the enemy, don't touch anyone, and you can't help. And when you tell a people they can't help and they can't be involved for an extended period of time, and you don't give them a way that they can assist with the problem, and you don't focus that around the message, eventually you have the system breaks down. That we should have been have you had an invite to a how to wash your hands properly seminar?
No.
How hard is it to make a town hall with a nurse in a Zoom call with a sink showing people how to wash their hands?
Okay, but
and then doing it in multiple languages.
Must have decided people weren't going to bother watching it.
When they're afraid in their homes, when they're talking, okay, look, they're closing down small businesses because one person can go inside and then go back home and create a cluster in their home. So they're willing to say that risk reduction, when you're on a less than 10 person scale for small business, is relevant. And you're telling me that a Zoom call that might reach 100 people for risk reduction isn't worth it to them? No, it's worth it to them.
Who did this? Who put on Zoom calls of washing hands? China,
private
Singapore?
Sector. No one in the public sector. This is the problem. And sorry. Who did this? Japan. Japan did public information, 3 Cs. We've talked about it before. And Japan fundamentally trained their public. And a few other countries have done it too, where they focus on the public messaging. Australia did it to some degree as well, and Sweden, kind of. But the general message of this is what you can do, and focusing on this is what you can do, and making it a more positive, we're all going to do this together, and this is the thing that you can do to do it together message, instead of sit down, be quiet, let the professionals come in and get out of our way, you're bad message, which doesn't help you. So, sorry, what was your other question?
Mask on, mask off. What happened there? Like initially everyone said you don't need to wear a mask, and then a month later it was wear masks. Okay. And so, almost seemed like they were trying to save masks for a while and were lying.
Yeah, that was part of it. So there was 2 things. The initial message of wear mask was the science-based message, where everyone in medicine just understands pretty much that, I shouldn't say everyone, but most people in medicine understand that wearing a mask reduces your risk from various types of infections. It's why masks are worn in surgery. It's common knowledge. So the general explain to the public, you need to wear a mask, or you should wear a mask because it reduces your risk, was going to happen. That's their first standpoint. The flip-flop to don't wear a mask happened for 2 reasons. The first reason was a supply issue, because people were overbuying masks and we were seeing shortages in hospitals, and we didn't want SARS to happen again, because the reality is if you got COVID at that time in the grocery store, you weren't a stage 4 cancer patient in the ICU. Right? They need to make sure they have masks in hospitals, because they don't want a whole bunch of people with very serious comorbidities to just die in the hospital. So that's the first reason. The second reason why they kind of flip-flopped is they didn't have enough time or they didn't realize that the Canadian public didn't actually know how to wear masks properly in large numbers. The majority of the Canadian public at that time, when just anecdotally, I suppose, wasn't wearing them properly, and they felt like they were protected and had battle armor because they had something on. So I think I've talked to you before about like the illusion of safety, or when people get an advanced braking system in their car, they start tailgating.
Yep.
So it's that same concept. They told you to wear the advanced braking system, but your advanced braking system was broken because you weren't wearing it properly, and then you started tailgating, in the medical analogy. So because they were
people were wearing masks inappropriately, but because they thought they were safer wearing this mask, even though it was worn inappropriately, they didn't physically distance.
No, it's not that they didn't physically distance. When they otherwise would have physically distanced, they made a conscious decision not to because they thought they were safer. So they behaved more risky with the mask on than the mask off. So the mask strategically, in effect, spreaded COVID faster because the people's behavior was being governed by the protection they thought they had from the mask.
And so, simply put, we just weren't putting it up over our nose and our mouth?
Yeah, well, you weren't making sure that it went basically from chin to nose, covered both. It was reasonably not airtight, but it wasn't like air pockets escaping everywhere. They weren't being worn masks. They weren't being worn properly. And there's still several people today that don't wear masks properly, but it's a completely different situation.
I got to tell you, I see so many people walking around with a mask on their chin, like just lying below their chin. Like, why, buddy?
I know. South Park named the term chin diapers.
Chin diapers.
Well, I mean, it's South Park, so what you gonna do? But anyways, so the point is, when you're an epidemiologist in public health, right, or if you're in public health, they're not communications experts. They're perfect situation. If people did this, they wouldn't get sick experts. So they go, numbers are going up because people are wearing masks improperly. It takes us X amount of time to teach them how to wear masks. It's faster to say, okay, guys, don't wear masks until we tell you how to wear them, and because we have a shortage. And once we're good with, we think we've told you how to wear them, we've put a bunch of ads up, and the shortage is handled, then wear masks again. But that is a very nuanced message, and people's attention span, and that is more than a soundbite.
And people got confused and lost confidence and faith and said the scientists don't know what they're talking about. Because one week it's masks on, next week it's masks off, then it's masks on again, and travel and borders. And there were so many mixed messages and changed policies that people lost confidence.
So instead of saying don't wear masks, they should have said, we have a shortage, we need masks. And frankly, they should have just, for communications, they probably should have just had the government in and take a bunch of the masks back from the private sector in this case, to be honest, and compensate.
Yeah, but the problem with saying we have a shortage is, when they said we have a shortage of toilet paper, don't go do a run on toilet paper. People went and got more toilet paper. People will react almost, against the society's better interests.
Oh, I agree. So what you do is you take them. The government has the powers in an emergency to take the masks. You take the masks, and then you tell people, we have taken the masks because there's a shortage in hospital, and then put out a big information campaign about how to wear them properly. And say, everyone, you need to stay extra distance right now because we need the masks in hospital, more are coming, etc. And yes, there's a bit of panic there, but you don't have the loss of confidence in the medical industry.
So failure number one,
significantly worse.
Failure number one was long-term care. Failure number two was communications associated with what to do. We're going to take a break for some messages and come back more with Alex Vezina, an emergency preparedness expert, on the failures of COVID-19 and, more importantly, where we are today and where we're going. Stay with us. Welcome back to the Brian Crombie Radio Hour, Saga 960. We're chatting about COVID-19, where we are, where we've come from, with Alex Vezina, CEO of Prepared Canada, emergency preparedness company. And Alex, we were talking about some of the failures, and you said failure number one was the way we dealt with long-term care. We didn't learn from SARS, and we made a lot of the same mistakes. And failure number two was communication, and confused communication and non-consistent communication that caused people to lose confidence in the scientific community and the political leadership. Fascinating. We're going to come back to that and talk a little bit more about that in the future, but maybe we can just jump to where we are today. We're in third wave in Canada, it would appear. The graph on the front page of the Sunday New York Times showed we're sort of like worldwide second wave, and the second wave is appreciably higher peak than in the first. We've got this vaccine rollout that appears to be, taking shape across the world, but yet we are at a peak in infections and in mortality, according to the New York Times. Where are we going from here? Are we going to have another wave? Is it going to die down? Are we going to go back to normal in the summer or in the fall? What do you think?
Globally, we're definitely going to have another wave. If you look at the expected timelines for immunization in quote unquote the developing world, they're looking to maybe get immunized best case mid 2022, 2023. So it's going to be happening and it's going to be spreading. And as long as airports are open, there's going to be a risk. So we have nowhere close to the vaccine production we would need for this thing to be over for future waves globally, first. Second, this thing is mutating faster than we thought it would mutate. Slightly, not a whole bunch faster, but it's not like it's mutating at the rate of influenza, but it is mutating in significant enough ways. I should say that carefully, where we need to matter, because viruses mutate all the time, but it's about if mutation's significant. And we're starting to see issues with vaccine efficacy with certain strains, and questioning whether or not, the pandemic of next year, these vaccines are going to work. So I think I've talked to you before about the whack-a-mole problem between, a new variant coming up and having to make a new type of vaccine, and vaccine producers having to decide which thing they're going to put on their production line with too many viruses to handle. So, that problem is still here. As far as Canada is concerned, Health Canada, if you listen to their briefs, came out with another recommendation and another brief, I think a week ago, where they clearly said that, with your best case of somewhat being out of this in August, there is about 15 to 20 specific things that have to happen in order for that modeling to be relevant. And when you look at the 15 to 20 things, anyone who knows what's going on today goes, not going to happen. So the Health Canada is basically saying, here's your best case. If you behave and do everything perfectly, we might reach it. And then everyone goes, yeah, well, that's not happening. They go, and then they say, but don't say, yeah, well, okay, well, then we're not open in the summer. What's your problem? So,
and sorry, the bottom line is what?
The bottom line
lockdown type measures. That's what Health Canada is recommending.
Yeah. Any doctor in Canada, given the data that Canada has and their perspective, is going to recommend some variant of any doctor in public health that is focused on COVID specifically, is going to recommend some version of a zero COVID strategy, a la Australia, New Zealand, etc. Because every time you get to 1,000 cases and open up, when 1,000 cases is as big, like Ontario, for example, where 1,000 cases is as big or bigger than your first wave peak, it explodes into a new wave. So if we wait until we get to 1,000 cases and open up again, give it 2 weeks, we'll be in wave 4. Like that's the underlying medical knowledge on this. And there is a reason for this. If I can kind of go off on a rant for about 2 minutes, you good with
Please.
that?
Yep.
Okay. So there's a reason for this. Whenever you use an unsustainable, highly restrictive measure on the public, and the unsustainable part is the most important part. If you can normalize it and people can get used to it, that's fine. But when you use something that's unsustainable and can't be normalized, people will need a release period. So it's kind of like, not a great analogy, but just trying to give you one. It's kind of like not, let's say you love chocolate and you give up chocolate for 2 years, and then you have chocolate for the first time in 2 years. Are you more or less likely to start engorging because you haven't had it in a while? Yes. It's that type of addictive behavior type of thing, that type of mentality. So when you restrict a population, the second you lift those restrictions, if they're not sustainable, they don't behave with the risk you expect. They behave more risky. So they they become more reckless than you anticipate. And every time you put the restrictions on them, if they don't have a release period where they can kind of decompress, they become more compressed and the release becomes more aggressive. So for example, in Peel Region in Toronto, because we have been in some form of gray zone, et cetera, lockdown since mid-November, whenever there is a small release for a few weeks or a month, as happened between second and third wave, people start behaving incredibly recklessly. You start seeing people not washing their hands the way they're supposed to. You see mask wearing go down drastically. You see people start basically creating parties in malls, like as far as public health is concerned, like pseudo parties in malls, in terms of the way their behavior is. They behave way more recklessly than is warranted for the phase that you've released them into. And every time you release them, they become more and more reckless. This means that your multiplier, the rate that your clusters are, the rate of the spread, goes from maybe it's 1 in 10 people to 1 to 10 people to 1 to 20 people. And then you compress them, and now it's 1 to 30 people, and etc. And unless
so what's the lesson there is that you've got to have reasonable relaxations on an ongoing basis?
The lesson is you can have a really high multiplier if you hit 0 or if you hit 2 digits. But if you compress people and then you open up when there's that many people, you're almost better off never compressing them at all, because you turn your curve from something that is flat into a roller coaster. And it's based on human behavior. So this is a hugely difficult problem, because now people are so compressed. If you actually opened everything up and went full Sweden, they'd just be in decompression mode for so long that, public health wisdom dictates we think we'd be in an India problem, percent per capita.
Which is sort of what's happening in Alberta, because Alberta's numbers right now are comparable to India. So from what I understand.
Yes, but it's a bit different. But here's the thing. With hospital capacity, if you have a steady curve, you can kind of build hospital capacity, anticipate demand, and deal with a horrible situation over a long period of time. If you're dealing with roller coaster, you always have way too much or way too little capacity, and it's not manageable. So unless we stop COVID until we get to 0 cases, which, by the way, in our second conversation, I talked about the 3 strategies, unless we, like a year ago, unless you stop COVID entirely, when you're doing something like this, people will need to decompress, and you will have massive spread every time because of human behavior.
Okay, so let's talk about it, because I believe you're talking the theory, which is excellent. I'm sort of dealing with some of the political realities. I think that the closure of playgrounds, the closure of tennis courts, the closure of golf courses this year, and then last year the closure of parking lots associated with parks was stupid, because it was doing effectively what you're doing. It was taking away those release valves that people had, and release valves that were very low risk. And then in addition, we talked at one point in time, Alex, about why don't we just allow all the stores and all the restaurants to open, albeit at reduced like 25% capacity, so that you would have people distributed out, versus what they ended up doing is closing things down, and everyone's clustered in Costco and the grocery stores and in an unsafe manner. And I walk through the grocery stores and people are not respecting 6 feet of distance. So I just think that what we've done is we've been silly in some of our policy implementations, taking away some of the release valves, and we've concentrated our population in too few areas that have ended up being sources of infection. What do you think of that?
Okay, kind of. So it's kind of, and the problem is, and this gets into really high level disaster management theory. But when you have a problem, when you have a crisis, disaster, etc., your decisions tend to become polarized, more polarized, the more severe the situation gets. So the worse the situation gets, the more all in you need to go on a strategy. And it's a phenomenon that happens with virtually every disaster and every hazard. But it takes a long time to explain. So it's just going to have to take me for granted on that for the moment. But I'll explain out why this matters. If you're going to stop COVID, If you're going to assume the strategy, we need to get to 0, which is going to be the public health wisdom in most cases on this, because it makes logical sense. You want to stop the virus. You can close parks, you can close businesses, you can close everything. It doesn't matter. If you're choosing to be unsustainable, then you can be as unsustainable as you want. You need to get to 0 as fast as possible. If you're getting to 0 as fast as possible, you declare martial law, keep people in their homes, bring out food rations, and you have people in spacesuits in the streets making sure no one leaves. Like if you're getting to 0, you try to get to 0 in 2 weeks instead of 2 months, and you definitely get to it in 2 months instead of 2 years. You do it as fast as possible, because anything you do to slow that is going to extend the time you need to take to keep the other unsustainable measures in. So for example, if you have to put in an unsustainable measure like closing non-essential businesses, and by not closing parks, you need to close non-essential businesses for 4 months, when if you close the parks, you only have to close the non-essential businesses for 1 month, you close the parks, you close everything. That's if you're being non-sustainable. If you're being sustainable, you can't do anything that's non-sustainable. And the problem there is you then have to assume spread risk, because anytime you do something non-sustainable, you start having the roller coaster problem. So if you're not going to close parks and you're not going to close parking lots when you're in a stage of the pandemic where we don't know if it's airborne and we're not certain on the outdoor risk, which was the situation back then, we didn't know if it spread less often outside, we just thought it might, then if you're not going to close those, you can't close anything that you can't sustain for 5 years. So it's very, very polarized. You have to go all in on one strategy. And can you imagine all of the extra deaths we would have if we did the only sustainable things? Counterpoint, maybe we wouldn't have the yo-yo thing and we would have less deaths if we did the sustainable thing. This is hypothetical land. The only way you can know is if you compare to other countries, but very few other countries have done what Canada has done. Really, it's like we can compare ourselves to the States, but it's not a great comparison. We can compare ourselves to Sweden, but it's not a great comparison. This is highly theoretical, frankly, because there's no data. There's no data on many things. But do you see where that's coming from?
Okay, so what you're saying is we've been trying to go with this unsustainable, very stringent measures, but we haven't been implementing them well, and people haven't been adhering to them, and then we open them up and people go crazy. And so that's what led to our second and our third wave. And so right now, Alex, we're in a rush between vaccinations and variants coming in, and borders being open and allowing more variants to come in. Where do you think we're going to be in the fall in Canada?
Exactly where we are now. Look. Okay, and here's the problem with the framing of that. I disagree that we're in a rush between vaccines and variants. I completely disagree. And this is based on what we were saying earlier. I think we are in a state where we are fundamentally failing when it comes to public health prevention. And I don't think that this is really, and I don't really lay this on public health. This is the whole system not being very cohesive. There's a variety of problems here, but this problem is a problem of not controlling the virus. We were supposed to be in a situation right now where we didn't have vaccines, and we were supposed to be doing other things to prevent this from getting out of control. Virtually every epidemiologist who has discussed COVID has said vaccines are not the solution, they're part of the solution. Virtually every public health doctor that's commented on this has said that basically the race between viruses and vaccines is at least partial misnomer. This is about the other
that's
stuff.
What the public
as well.
thinks right now. The public thinks and the politicians think and are saying it's a race right now for vaccines.
Yes, because it's a very quick buzzword and people can resonate with it. And in many cases, the politicians are panicking because, especially, federally and provincially on vaccine rollout, because it is the narrative, and everyone's forgotten that in December, they told you the timeline and we're ahead of schedule based on the timeline they gave you in December. Like, they told you how long this would take, and we're ahead of schedule. People are dying because they're not washing their hands and because they don't figure out distancing and can't wear masks. That's been the problem the entire time. We're still not there. Look at Japan. They have cameras in stadiums tracking carbon dioxide emissions to see if there's too many people in a building. Look at other countries that recognize whether or not ventilation is relevant. In Canada, we still believe that moving air in a building is worse than stagnant air in terms of transmitting COVID, when the CDC and the WHO disagree. Okay, like, come on. This is so much bigger than vaccines. And everyone who is an expert, basically, not everyone literally, but you get what I'm saying, has said the same thing. Time and time and time again for over a year. Look, I've been in the meetings with the elected officials too, okay? And I've been in the meetings with the other experts and et cetera, and I'm in the middle of all this, as you know, and I viscerally understand where you're coming from, but the message is so backwards, it's infuriating. But I mean, I knew this was going to happen, so whatever. Next question.
So we're causing deaths because we're not washing our hands, we're not physically distancing, and
we're not doing the basic stuff that we've said the entire time prior to vaccines that we should be doing.
We're not doing the basic stuff.
And there's a variety of reasons for it. People are tired. Unsustainable measures make people want to do them less. I'm not placing this on people for the blame. That's not fair, and it's not accurate. And I've actually been critical of the medical sector multiple times of giving people flack for being bad. If your doctor tells you to drink water, exercise, get adequate sleep, and manage your diet, and then you don't do it, whose fault is it?
Both of ours. Mine for not following their suggestions, and theirs for not motivating me correctly to adhere to their suggestions. Correct.
The second part is really important. And the hubris that people are just incapable of being intellectual and thinking that, you know, I told them so they should know better, and washing my hands of the plan is unacceptable. If you give someone advice and they don't follow the advice, your advice was practically useless. And I mean useless in a practical sense. So if your job is to provide advice and people don't listen, advice is useless. Same thing applies to me. If I advise your listeners to a bunch of different things and they don't listen to me, or if they don't agree, fair enough. But if everything I say is completely discounted, then the advice I'm providing is useless because it's not being acted upon. If you tell people they're bad and it makes them go, well, screw you, I'm not going to do it, you're not doing your job. So
we're chatting tonight with Alex Vezina, CEO of Prepared Canada, an emergency preparedness expert who's telling us that we're just not listening to government officials and public health officials. We're not doing what they're saying, but it's not our fault. It's because they're not providing the advice in the proper manner. Kind of interesting. We're going to take a break. Stay with us. Welcome back. We're chatting tonight on the Brian Crombie Radio Hour with Alex Vezina. He is the CEO of Prepared Canada. He's an emergency preparedness expert. And Alex, you've listed two failures. The first failure you talked about was our failure in long-term care in regards to COVID-19, and that we didn't listen to and adhere to some of the lessons we had from SARS. The second one we talked about in great length was communication, that we didn't communicate a solidified, consistent point of view, and that communication that we provided from public health to do a lot of public health measures, for whatever reason, wasn't listened to. And so therefore the communication, the persuasion, the advertising, the message wasn't packaged correctly, such that people would listen to it, follow it. And so therefore you're saying it was effectively useless. Any other failures you want to talk about?
Yeah, and look, I've been really critical on doctors because, frankly, I'm friends with a lot of them, and they're critical on me, and you're critical with your friends, and you know, we don't like hearing yes people for each other. We like to make each other better. So I think one thing that I think is important to really contextualize for people is how difficult it is to actually provide advice right now inside the decision-making organization that is government. I'm going to speak from a provincial to municipal perspective here for a moment. I'm not going to get into federal because there just won't be time. The reality is that the role of a medical officer of health for a given region is to try to provide advice and guidance on how to keep people alive. Most of the time from physical issues. Generally speaking, they don't have a lot of time to really focus on mental health, but they'd like to. They also don't have many resources, and they don't have the people to do what they need to do. They usually can't do their own enforcement either. So they are one person who an elected official can basically call and ask, what should we do about blank? It's the same type of deal as if you call your doctor and say, hey, I'm sick, what should I do? A given mayor can call their doctor and say, hey, my city is sick, what should I do? Just as a person may not listen to their doctor, a city may not listen to their city's doctor. It's the same kind of problem. Now, do you ask your doctor for financial advice? No. And does your doctor consider financial advice when they're giving you medical advice? No. Usually not, right? And this is the way they think, and this is their job. And they have been blatantly clear, publicly and privately, that they have a very specific thing that they speak to, and they do not expect to be the ones making the decisions. I have talked at length in other conversations with you, Brian, about the importance of emergency managers existing and the fact that we basically haven't existed internally to sort all this out. But the problem is doctors haven't been empowered to do their job. They've been empowered to do a different job, which isn't their job. And it's kind of ludicrous. We're asking doctors to consider economic damage and make decisions when it's the job of the decision maker to consider the economic damage and the medical damage and make the decision. Medical officers of health are, in general here, perfectly happy, are perfectly willing to accept that you do something that they fundamentally disagree with. That's okay. They're going to do what they do. They're going to meet their objectives. They shouldn't be in a position where they're making the decision around something that isn't their job, and politically they've been forced to do it. That is ludicrous. So is what you're saying is that political leaders have abdicated their responsibility to make decisions and have allowed public health doctors to be making the decisions that should be made by someone more senior that's taken into account not just public health issues, but economic issues as well? The problem is there really is no one senior right now that does that. That's supposed to be an emergency management agency. You bring in your emergency managers to manage the emergency. Kind of the point. Our emergency managers are buried in the Solicitor General's office and are focused on enforcement practices. We don't have emergency management in our leadership offices, and that's where they're supposed to be. Have you seen how frazzled Ford is?
Yeah, well, it was interesting. Doug Ford went on, and I think it may have been during a off-camera time period, but he was recorded saying no politician in Canada is going to go against his public health people.
No, and of course they're not. It's politically, you can't do it. It's politically untenable. And further,
but what you're saying is they should, that an emergency preparedness person should take into account other issues, not just.
Yes, but it shouldn't be them doing it. They should have a group of people whose job it is to fall on the sword. Okay, that is the point of emergency management. We make the really hard calls for the betterment of everybody long term, and we accept the consequences. Politicians in Canada are not trained to do this. You cannot reasonably expect an individual to make sustained life or death decisions for 14 months. Like, do people realize what they've actually asked Ford to do? It's military generals can't do this on that time schedule. They have alternates. This is crazy. He doesn't have a support team that specializes in crisis decision making. This is why they had to bring in the consultant to make an emergency structure. Like this, we haven't fostered this, and this isn't a Ford problem. We haven't fostered this as a country ever. We started after 9/11, but then the funding went down. Like we've categorically missed the mark on this to some degree. I think it's Mayor Nashi, to some degree, in Calgary. In some degree, they have actually done it fairly well, but not on the grand scale you need. The leaders don't have the support they need. They should be receiving advice where an emergency manager can go in front of a microphone and then say something completely politically untenable but convincing, where the public goes, I hate that person, but I understand why they're doing it. And then at least the politician has some cover fire to make the correct decision.
Okay, so failures. Number one, long-term care. Number two, communication of public health issues that was not consistent and done in a useful, applicable manner. And number three, lack of emergency management. Anything else, real quick?
It takes too long to explain. We'll do it. We'll go into the other ones at another time.
Give me a top line.
It's going to relate to those three in general, to be honest, in some way. There's some really specific problems with the way organizations are designed that do it. There's when your personal goals get in front of what you need to do for your job. So when selfish behavior gets in the way of doing what your job needs to do for the betterment of society, and organizations not incentivizing people to do the right thing.
Sounds like politics.
Sorry?
Sounds like politics.
Sounds like every job there is. But there's that's organizational behavior. It takes a long time to break down.
Alex Vezina, thanks so much. I got one last question for you.
Sure.
It was reported on CNN this weekend in a poll that 50% of Republicans refuse to take the vaccine.
Yeah, okay.
By definition, isn't that, like, if you're right, if people are right that we're going to get another wave and the variants are going to come and that the virus is going to be with us, doesn't that mean that a whole bunch more Republicans are going to die than Democrats?
Sure. But I mean, I focus on making sure cars don't get into accidents instead of focusing on why everyone isn't wearing a seatbelt. I'd like if they wore a seatbelt, but I want to make sure that we have other ways to make sure there isn't an accident. Once again, it's the vaccine problem. We don't have it globally distributed. That's nice. We need to make sure that the other stuff is being done too, frankly, because is it more effective to not get into an accident because you're driving safely, or not die in an accident because you're driving safely, or more effective because you're wearing a seatbelt? What's the better risk reduction measure?
Let's drive safely.
Yeah, I'd say so. The analogy here, once again, is that vaccines are the seatbelt, just in case.
So wear a seatbelt, but drive
safely. Wear a seatbelt, but you might want to do the other stuff too and not get into the accident in the first place. And
so
that's
wash your hands, wear a mask, physically distance, and get a vaccine. Okay. And the vaccine is just the thing to do it, like the seatbelt. Alex Vezina, CEO of Prepared Canada.
One last thing. Australia, New Zealand, and Japan don't have vaccines in large numbers. Australia has a vaccine production problem. Go look at Australia's numbers.
We can do it without vaccines. Alex, thanks so much for joining us. That's the Brian Crombie Radio Hour for tonight. Good night, everybody.